Well, hello. Thank you so much for the opportunity to speak to the Dravet community and to present to you a beginner's guide to Dravet syndrome. And I'm very excited to share with you some very recent work we have done to try and look at the evidence to frame the classification criteria for Dravet syndrome. So let's just starting with my disclosures and moving to learning objectives, which are to understand the clinical features of Dravet syndrome. And I'm going to start by going through what we usually and what we have historically taught doctors about how to diagnose it. And then I'm going to share with you the evidence from a large cohort of patients with SCN1A associated Dravet syndrome to use that to define the diagnostic criteria. And the aim of this is to facilitate much earlier diagnosis of Dravet syndrome so that we are ready with our patients for when new precision therapies are available. So many years ago, I developed a puzzle really to illustrate the complexity of a Dravet syndrome diagnosis. And with Dravet syndrome, historically, we've always taught that you see a previously well and developmentally normal baby come along with their first seizure. And the seizure often has these features with jerking down one side, which we call hemiclonic, and is historically quite prolonged. Well, we've thought that they presented with status epilepticus, which is defined as at least 30 minutes, and often the baby has a fever. So the first seizure in Dravet syndrome is considered usually to be an episode of febrile status epilepticus with jerking either down one side or a generalized or bilateral tonic-clonic seizure with stiffening for the tonic and clonic, meaning the jerking, with a prolonged seizure, with onset usually between 6 and 12 months of age. And then the baby goes on to have frequent convulsive seizures. They then go on often to develop other seizure types, commonly focal impaired awareness seizures, myoclonic seizures, some have absence, and often they have non-convulsive status epilepticus. So here you see a 21-month-old little boy having a myoclonic seizure, which is triggered by the photic stimulator that you're about to see flash. And there's a little cluster of seizures. Okay. And you can see he doesn't like that cluster of seizures very much, so the cluster of myoclonic seizures is triggered by that photic stimulus. Not many children with Dravet syndrome are actually photosensitive. Now here you see another little 2-year-old boy with a different type of seizure, which you're seeing there. And this is an absence seizure with eyelid myoclonia. And there's another one with very subtle eyelid jerking or twitching. And you can see that they're really very frequent in this little boy. And every time he has one, he may lose, there's another one, awareness for a moment. Here's the same boy, a little bit older, now about 4 years of age, and you can see there some little jerks associated with his myoclonic eyelid absence seizure with eyelid myoclonia, and also some head loss of posture, a tonic element to his very severe absence seizures. Now, what about the developmental course? Well, many children with Dravet syndrome have normal development until they're 1 to 2 years of age, and then their development slows or plateaus, such that they tend to walk a little late. The normal age of walking is about the average age of walking is 14 months, with the upper limit of normal walking at 16 months. And in our study with Jill Rodder, we showed that the gait of children with Dravet syndrome, people typically walk at 16 to 18 months, so just a tad later than is normal. Language development is slow, and they may show regression of developmental profile when they have a prolonged seizure, so that they then take a few weeks to catch up, if indeed they actually do catch up. Most of the patients with Dravet syndrome have a poor cognitive outcome, with 50% having severe intellectual disability, 30% moderate, and about 20% mild. Only very rare individuals have normal intellect by the time they reach adult life. What about their examination findings? Well, the normal baby is normal to examine, the young child is normal to examination, but they do have longer ataxia or unsteadiness of normal walking, which we call physiological ataxia, because all babies are a bit slow when they start to walk, or a bit unsteady is probably a better term. And this physiological ataxia is a bit prolonged in a baby with Dravet syndrome. But as they grow older, they do develop very mild pyramidal signs, which you can find if you examine them after about 9-10 years of age. And then we showed in our orthopedic study with Jill Rodder and Kerr Graham that they develop this unusual crouch gait after they go into puberty, which is characterized by flexion here at the hip and at the knee joint as shown there, and also plano-abductor valgus deformities of the feet. And this crouch gait is a problem as they grow older, in that it limits long distance walking, such as when they go to the shopping centre, and families often with adults with Dravet syndrome will need to use a wheelchair if they're going a longer distance, although the individuals can certainly still walk around the house. Now, what about the EEG? Surprisingly, it's often normal in the first 2 years of life, despite the baby having seizures at 6 months and about 9 months and 10 months and 1 year and developing other seizure types. It may still remain normal. But after about 2 years of age, you see frequent epileptiform activity, and here you see some irregular generalized spike wave activity, but they can also develop multifocal discharges quite commonly. And finally, what about the genes? Well, as you know, this has been transformed, this area, since the 2001 discovery by Claes and from the de Jonge group, that 7 out of 7 children with Dravet syndrome had a pathogenic variant in a gene encoding the sodium channel alpha-1 subunit, which you can see here in the pinky purple, and this makes the pore of the sodium channel through which the sodium ions pass. And here you see the sodium channel embedded in the cell membrane. Now, these 4 transmembrane domains of the alpha-1 subunit, or SCM1A as the gene name, are shown here in a 2-dimensional cartoon. And you can see that really the mutations are displayed throughout the gene, and about 40% are truncation, shown in red here, and 40% are missense. And then you have other types such as splice site and very small intragenic or larger genic deletions. And we found back over the last 10 years that more than 80% of patients with Dravet syndrome have SCM1A pathogenic variants, which is the new term for mutations. So I thought I'd move there from that basic delineation of Dravet syndrome just to touch for a moment on the inheritance of the SCM1A mutations while I'm in the genetics part of this talk. And most of the patients with Dravet syndrome have a de novo mutation, which means that the mutation is present in the child but not present in mum or dad. And that's very important in terms of recurrence risk counselling for the parents if they go further to have another child. But sometimes the mutation may actually be mosaic in the child. And so I thought I'd just speak for a moment about mosaicism and the importance of mosaicism in Dravet syndrome and more broadly in the genetic developmental and epileptic encephalopathies. So let's start with what is mosaicism, and I'm using here a beautiful Aboriginal painting of a lizard because it's rather beautiful artistic display of mosaicism where you see different populations of cells or different colours in the picture. And in this lovely picture from Ampeduri's paper, you can see that mosaicism is where you have two populations of cells, the normal cells shown here in grey and the mutant one, which happened here after the egg and sperm have got together to make the zygote and the embryo, and then you have a mutation that happens by chance, and then that may be limited to just one tissue, such as brain, or it may be in more than brain, in many tissues, or maybe at a low level throughout. Now, one of the interesting points is that we all have a certain degree of mosaicism. And if mosaicism of a pathogenic variant is limited to the gonads, be the gonads being the eggs or the sperm, then if that egg or sperm goes to make a baby, in a zygote and an embryo, then that mutation will be throughout the child, and you will have an affected non-mosaic baby. So you're going where there is a population with two cells, the normal cells and the mutant cells, either mosaic in the patient or mosaic in the parent. So let's think about the patient first. And this is from a lovely Dutch study where Iris de Lange and her colleagues looked at 113 patients with Dravet syndrome with SCN1A mutations, and they covered each child's mutation more than 1,000 times to see if there was any evidence of mosaicism in that child with Dravet syndrome. And they found that 7.5% of their Dravet probands were actually mosaic. So the patient was mosaic, and this would have been missed with classical sequencing. They then analysed this for this group of patients, and they found that if the patient had a truncation mutation, they actually had milder features if they were mosaic, which makes sense, if you will, because it's not in every cell, and therefore maybe the patient is a bit more mildly affected. In order to do this study, you need to cover the mutation at very high levels in the study. And you can see in one individual, they even did it more than 7,000 times. And this finding is important for the patient, the proband, but it's also really important for their parents, because if the mutation is new in the proband, then that means the parents do not carry it, and it gives them a much lower risk of having a second affected child, which in lots of ways is everyone's worst nightmare. So what about if it's in the parent here and you're thinking about a mutation that may be at a low level in the parent? Does that ever happen? Well, in a study that I did with Candice Myers and Heather Mefford, we looked at families of children who were thought to have de novo mutations of different genes, but the child had a genetic developmental andepileptic encephalopathy. And I just wanted to share with you two of the examples from the Dravet cohort in this study, which was about 40 Dravet families. And one of the families that I look after had two affected children with Dravet syndrome, a girl and a boy. The girl has recently died of SUDEP, very sadly. And so by the time a family has two affected children, it's obvious that one of those parents must be harbouring this SCN1A mutation. So there was a little bit more information in this family, which is that the father had had febrile seizures as a child. And when we found the mutation in the children, we looked at the parents both 200 times for the children's mutation, and we found that the father was 28% mosaic for the mutation. And the father is now in his late 40s, and his seizures have come back in adult life, showing that this 28% is not such a low level, and so he continues to have epilepsy. In the other family, we had a little girl with Dravet syndrome, quite a high performing child with Dravet syndrome, in that she has only mild intellectual disability. She had a mutation. Her mother also had a history of febrile seizures and was 17% mosaic in blood. So that means they're certainly at risk of having a second affected child. So just thinking about parental mosaicism, the take-home message from this study that we published in 2018, was that the frequency of parental mosaicism is underestimated, that 8% of patients with the genetic developmental and epileptic encephalopathies who are thought to have a de novo pathogenic variant actually have a mosaic parent. And those parents, those families are at much greater risk of having a second affected child. As you can see here, this poor family has 2 affected children, not with Dravet syndrome, but with another developmental and epileptic encephalopathy. One of the red flags to this scenario is if a parent has had any seizures, such as febrile seizures. And we found that the parent was more severely affected if they had a higher percentage mosaicism, such as in the first family I showed you with the father affected. So that's the mosaicism story, that you can have a mosaic unaffected parent with low-level mosaicism or a mildly affected parent, and you want to diagnose that prior to them having a second child. And the third scenario, which would be more common than the mosaic scenario, is where you have a mildly affected parent with a disorder called genetic epilepsy with febrile seizures plus a much milder epilepsy, and the parent is affected and has handed the mutation to the child. Now, we don't know why in this scenario, where a parent is heterozygous with half the cells having the mutation, why the child should have a much more severe phenotype such as Dravet syndrome. But that, of course, is a key question, and we suspect it's due to other genes being involved. So all of this together really builds the picture for what we have always been teaching people. This is Dravet syndrome. But the question is, are our criteria for Dravet syndrome right? And I've put up this picture because we've tended to call this our fuzzy edges study, to say what are the edges of this syndrome, and are we getting it right when we teach doctors and parents that this is Dravet syndrome? And this is important in helping us to diagnose at what age we can actually make a diagnosis as this is becoming of critical importance as we enter precision medicine therapies. Do we really need to wait till a child is 2 or 3 years of age when all the features are present? Can you, in fact, diagnose it when they first present with their first episode of status epilepticus? Maybe you require the second episode. And what if the child doesn't have all the typical features? Can you still make a diagnosis? So this aim of this study was to try and develop evidence-based criteria for Dravet syndrome. And I'm indebted to my colleagues, Dr. Wanhui Li from Shanghai, who came and spent a year working on this study with me, and my wonderful chief clinical research scientist, Amy Schneider, who's done a huge amount of the work. So in refining the class, we're using this study as really an example of how you can take a large cohort to refine the classification of the prototypic, if you will, developmental and epileptic encephalopathy. And we'll use this to delineate the limits of Dravet syndrome and to help our colleagues and families to make a diagnosis if the patient doesn't quite tick all the boxes that I've talked about. Why does it matter? Because delayed diagnosis in real terms means that the patients can be given the wrong drugs today, the wrong anti-seizure medicines. They can cause seizures to be worsened and thereby make development plateau or regress with impact on long-term outcome. And then importantly, we're just in this beginning of precision medicine's trials, particularly of exciting advances with gene therapies. So we need to make a diagnosis as early as possible so we can make sure the right children can get it before their developmental consequences of the SCN1A mutation are noted. And this is just by way of example to show what happens if you miss the diagnosis, you don't think about Dravet syndrome, and you give the wrong drug. And this was a seizure diary from a baby in 2018, but I know the same thing has just happened this year in another part of Australia in 2021. And you can see here the baby had seizure onset here at around 4 months of age and was commenced here on levetiracetam at 6 months of age. Seizures continued with the red lines here and there, not too frequent, but not too infrequent either. And if they're scary seizures, this would be pretty worrying. And here the neurologist decided that the seizures weren't adequately controlled, with which I agree, and they started trileptal or oxcarbazepine. The other one this year, they'd been started on carbamazepine, which is a brother drug, and you can see here the seizures just took off. And this is what these drugs do. They are sodium channel blockers. So in a disease where the sodium channel isn't working and you block it further, you create more of a problem. So recognition of Dravet syndrome is critical. Early recognition of Dravet syndrome is critical. So in the study I'm going to present to you, we had 205 patients with Dravet syndrome from our epilepsy research database. And these patients have been studied over the last 15, 20 years. And we analysed their early clinical features, which involved parental interview, a validated seizure questionnaire, medical histories. Just over half were female. Their median age at the time of this study was 8.5 years, but you can see they ranged from 10 months to 60 years in age. And here are their SCN1A mutations with 42% truncating, 42% missense, and a smattering of other types of SCN1A pathogenic variants. So let's go through our puzzle and see if what we say is actually correct. Now, I haven't said to you that the onset is under 12 months, but some of the very senior groups in the Dravet world have published that really seizure onset in Dravet syndrome is always under 12 months of age, and I wanted to call that into question. So here you see the ages of seizure onset in our cohort of 205 individuals. Now, the data I'm presenting, we don't have full data for every patient, but they're hugely large numbers of patients. And you can see here that there are some that are out after the 12-month age group. The median onset was 5.75 months of age, and here you see the 12-month point. Here you can see in our cohort that we had a number with onset after 12 months. Here I'm showing you those with truncation mutations and 2 more with missense mutations. But what about the rest of the literature? Well, there are quite a lot in the literature with onset after 12 months of age, as you can see by these asterisks, showing that onset over 12 months of age is not unusual. Now, what about mosaicism? As you can see, the top end of our cohort had onset, little girl had onset at 20 months and was 22% mosaic. So maybe she has a bit milder and therefore has later onset. But is that always the case for mosaic patients? So this is where the patient, remember, has 2 populations of cells, some with the normal SCN1A and some with the mutant form. And you can see in our study, we had several other mosaic cases with the percentage mosaicism varying quite a lot. And this particular patient is fascinating because he has 8% mosaicism of one mutation and 7% of another mutation. It's the same amino acid, but with a different mutation. And yet we still had one normal copy, as you would expect in Dravet syndrome. What about the rest of the literature? Well, the De Lange paper I just mentioned was only about the mosaic cases, and you can see here that many of their mosaic cases had onset at 12 months or younger, showing that mosaicism is not the sole explanation for the later onset case. So let's move on then to other seizure, to the initial seizure type. And we teach that babies tend to present with fever and with prolonged seizures, which are hemiclonic most commonly and then generalized. So is this true that they have fever with the first seizure? Well, yes, but it's only 55% and 45% do not have fever. So fever, if it's present, is helpful, but if it's not present, certainly does not exclude a diagnosis of Dravet syndrome. One of the key points I find useful as a clinician is that babies with Dravet syndrome often fit at a lower temperature. So when we think about a febrile convulsion or a febrile seizure, which occurs in 3% of Australian or Caucasian children, we always say the fever must be over 38 degrees Celsius. But many of the babies presenting with common or garden febrile seizures have temperatures of 39, 40, 41. And yet here, the median temperature was a low high temperature of 38.2 degrees Celsius with quite a wide range. And you could argue 37.7 is not even febrile. Another key issue that came out of the cohort was that 3% of the children had never had a seizure triggered by fever, even into older ages. So not every Dravet patient is fever sensitive, although by far the majority are. So then let's think about the first seizure type. Well, again, we only found that a third presented with a hemiclonic seizure and more than half present with a tonic-clonic seizure, which may be generalized or a focal to bilateral tonic-clonic seizure. I think it's impossible to tease those apart. And here you can see that they could present with other seizure types, including myoclonic seizures as the initial seizure in 4%, focal impaired awareness seizures in 5%, and 3% actually have several different seizure types at their initial presentation. The take-home message from this point, though, is that the presenting seizure type is a generalized tonic-clonic seizure more frequently than a hemiclonic seizure. So then let's turn to how long does that first seizure last? Well, we tend to teach that they present with status, and is that the case? Well, it is for 34%, but you can see there are a whole range of different initial durations of their first seizure, with 27% having a brief first seizure. And are they always, close to 5 minutes? Well, 9% are, but 17% look just like an average brief generalized tonic-clonic seizure. So I think one has to think about Dravet syndrome if they present with status epilepticus, defined as a seizure lasting more than 30 minutes. But one also has not ruled out Dravet syndrome if they present with a brief seizure. So then do they stick with always having long seizures, or do they have short seizures too from the beginning? And here you see our breakdown of the first seizure, second seizure, third and fourth seizure experienced by each individual. And you can see here the numbers of patients in each making up the 100% for each one. And the take home here is that status epilepticus is still the first, second, third, fourth and fifth seizure for 20% of patients, but they're, as they go through more seizures, their seizures tend to get briefer. And looking at that data in a slightly different way, the median duration of the first seizure in Dravet syndrome is 15 minutes, but the maximum duration in our cohort was 3 hours. And the median duration of the fifth seizure was only 5.5 minutes, with the maximum 1.5 hours. So I think one has to have a very broad understanding of the duration of seizures in children presenting with Dravet syndrome. And that they don't all present with status epilepticus. So looking at this data a different way, and as you can see, we've done a very detailed dissection of this data set, how long between the first seizure and the second seizure? And I think it's important that we, again, or I have for many years taught that you have the first seizure at 6 months and then the next month or 2 months later, you have the second seizure. But that is not always the case. So the median time between the first and second seizure is a month, which is what we've taught. But look out here, it's almost 250 days between the first and second seizure in our outlier here. So that is like 3/4 of a year. And I know many people wouldn't think about Dravet syndrome in that individual. In the second to third seizure, it's again 30 days, but again, look at these outliers out here, which are much longer between seizures. Then it tends to start shortening the time between seizures. And you can see here the medians are down to 21 and 24 days, but with far fewer outliers. So then let's walk on to additional seizure types and what age do they begin? Well, we've already shown you this data in a different way, that the median age of the first seizure type is 5.75 months, but the youngest child with classical Dravet syndrome presented at 6 weeks of age, and the oldest was that girl who was mosaic at 20.6 months. We tend to say then between 1 and 5 years of age, you get your second seizure type, but is that right? Well, actually, it's so at the point is after the 12-month mark. Actually, it's not right. The second seizure type had a median onset of 9 months with a minimum onset at 3 months. So you can see not long between these ones beginning and their second seizure type. And equally, the maximum onset of the second seizure type over 25 years of age. And then looking at the third seizure type, I tended to think that it was a bit later, but no, the median onset is at 15.5 months, between 4 months and 8 years. So what about these additional seizure types? What are the most frequent ones, and what types of seizures do these patients with Dravet syndrome actually have? And you can see that 96% have tonic-clonic seizures through their lives, 73% hemiclonic, 72% myoclonic, and this often may not be apparent until adolescence or adult life. Focal impaired awareness seizures at 72%, absence in almost 60%. Now, we tend to say, well, they're not really prone to tonic seizures, and although there's some lovely work from the French showing that you can have tonic seizures more in adult life, but this is also including younger children, and we found a quarter had tonic seizures. Equally, some do not believe that you have atonic seizures in Dravet syndrome, which refers to lack of tone, where you suddenly crumple to the ground. And we found 22% had atonic seizures. And what about status epilepticus, where you have a convulsive seizure lasting more than 30 minutes? Well, 89% had this at some time in their life. So it didn't necessarily present with it, but they had it at some time. And 24%, or a quarter of patients, had non-convulsive status epilepticus, which is where they may not be with it, they may be a bit more dribbly or unsteady, and it can last at least half an hour, but it can last half a day or a few days, this non-convulsive status, which has been termed by the French as obtundation status. And then looking at this data in a slightly different way, you can see here, according to seizure type, which was the first seizure type with a tonic-clonic seizure in 100 of our cohort, and the second seizure type, the first seizure type was hemiclonic in 65 of our cohort, and then you can see when the seizure type came along for each child. So moving on then, let's just think about the development of the children, because we teach that the development is normal in the first year of life and then the child has poor outcome. Is that actually correct? So we tend to think of normal development the first year of life and then developmental slowing. So when did our patients actually develop, start to show slowing of their development? And interestingly, whilst the biggest group was between the 1 and 2 year mark, it was about half the children, just over a quarter started to show developmental slowing or regression before 1 year of age. And interestingly, at the other end, some did not show it till 4 or 5 years of age. 4 of the patients actually had developmental delay prior to seizure onset, which in general we think is not the case with Dravet syndrome, but it shows that this can occur. And the median age overall of developmental slowing or plateauing was 20 months, with a range from 3 months to 5 years. So the last part of the Well, the next point I wanted to move on to then was the mortality in Dravet syndrome. And in this cohort, we've previously published on mortality, as have the Japanese and other groups. And the take-home message here is that Dravet syndrome carries a mortality of 17% by 20 years of age, meaning that 83 out of 100 people will be alive at 100 years of age. Now, this, of course, is every family's worst nightmare, and it really is a worry for families with Dravet syndrome and also for their families and their community and their doctors. And this is from our data set, just to show you the mortality we had seen in this group of patients with Dravet syndrome. And this follows on from a publication that we did of the first 100 patients in about, which is published in about 2016. And you can see in black the patients with sudden unexpected death in epilepsy, or SUDEP, which of course is the biggest group. We also described the presentation of cerebral edema following an episode of status epilepticus, where the brain swells and the child ends up in intensive care but doesn't survive. And we described these 5 patients with my colleague Ken Myers a few years ago. And this is really devastating and requires some very active trial to try and figure out how we can help these patients. Asphyxia here in this individual, and some patients had accidental drowning, one of them in the bath, tragically. So how has this work changed thinking? Well, just to highlight these points I've discussed, that development initially we have always taught is normal under 12 months of age, but in fact more than a quarter are delayed prior to 12 months of age. Onset is from 6 weeks of age to 20 months of age. The most common presenting seizure type is a tonic-clonic seizure on both sides. Almost a half do not have a fever with their first seizure. Status epilepticus occurs in about 35%, but more than 27% have a seizure under 5 minutes with their first seizure type. They develop a second seizure type often before 12 months, contrary to what we've taught. They have no hemiclonic seizures at any time in 27%. 7% never have status epilepticus. 3% never have fever sensitivity. And tonic and atonic seizures occur both in more than 20% of individuals. So why are we bothering with these fuzzy edges? And that is because we really need to get these facts right if we're going to be able to identify the right patients for gene therapy trials. So the last point I wanted to talk about with Dravet syndrome is we say that currently more than 80% of patients have mutations of SCN1A. So is this actually correct? So we looked at our patients with Dravet syndrome in our research and clinical studies, and we had 139 definite and 159 probable, which were included the 138. And we looked at our SCN1A mutation rate, and you can see it's well over 90% for both groups. But that was not all. We also had a smattering of patients with mutations in other genes, which we have previously reported. So overall, in our Dravet syndrome cohort, we've solved around 95% of patients. So I think we can take the SCN1A mutation rate to above 90% now if you recognise the phenotype. Now, in the last part of my talk, I wanted just to differentiate other forms of SCN1A epilepsies, or particularly developmental and epileptic encephalopathies, because we know at the mild end we have genetic epilepsy with febrile seizures plus, and I don't think that is difficult to differentiate. But if you have a SCN1A pathogenic variant returned in a child with a severe epilepsy, is it always Dravet syndrome? And here we've got to think about this much more severe disease called SCN1A, early infantile developmental andepileptic encephalopathy. And we reported this phenotype back in 2017 together with my colleague, Lynette Sadlier. And in this study, we had 7 boys aged 6 to 12 years of age, just by chance boys. I don't think this is particularly a male disease. And they all had seizure onset a bit earlier, between 8 and 12 weeks of age. So clearly there's overlap with the Dravet cohort. They also presented with hemiclonic in 5 individuals and generalized tonic-clonic seizures in 2 boys. But what was different here in this group of patients is that early on, 5 had tonic seizures, which would be very unusual for Dravet, although, as I've mentioned, they can occur later. And 5 had epileptic spasms, which do not occur in Dravet syndrome. The other issue with this group is that they are much more profoundly impaired. It is not clear if their development was normal prior to onset when they were first recognised at 6 to 16 weeks of age, but they are profoundly impaired in that they are non-verbal and they are non-ambulant, meaning they don't walk. The other important point about these children is that they have a movement disorder which begins at 9 weeks to 20 months of age. And here you see 3 unrelated boys with the same mutation, or with this dyskinetic, hyperkinetic movement disorder, which means moving all the time, with those little jerky movements of chorea, and the odd posturing of their hands is called dystonia. The other thing to bring your attention to is they have this very unusual mouthing, which is an orofacial myoclonus and dyskinesia. So a very unusual movement disorder that helps to differentiate this particular syndrome from Dravet syndrome. Their EEG was similar in that it was normal initially and then showed generalized and multifocal epileptiform abnormalities. And interestingly, 6 of our 7 patients had exactly the same mutation, a recurrent threonine 226 methionine missense mutation. So this is just where there is a change in the amino acid causing a change from one amino acid to another rather than truncating the protein, which is what I talked about before. And ironically, we tend to think of missense mutations as milder, but here you see a missense mutation, which is much more severe. So we hypothesized that this missense mutation was actually having the opposite functional effect. We know that Dravet syndrome and GEFS plus, or genetic epilepsy with febrile seizures plus mutations with loss of the sodium channel function. So it's not working as well. And we hypothesized that this early infantile profound SCN1A developmental and epileptic encephalopathy was actually due to gain of function, and that is because it looked much more similar to SCN2A and SCN8A developmental and epileptic encephalopathies beginning under 3 months of age. And my colleague Geza Barecki and together with Steve Petru at the Florey Institute proved that this was indeed a gain of function mutation. So it's really important that if you have a child with SCN1A mutation, that you understand the phenotypic difference, the difference in presentation between these 2 syndromes, because you treat them very differently. In the gain of function babies, you would use a sodium channel blocker such as carbamazepine, oxcarbazepine, phenytoin, whereas in the loss of function babies, you would not use a sodium channel blocker. So I hope this study has shown you why it's important to clear up these fuzzy edges to define Dravet syndrome so that we understand the phenotypic spectrum, we can see a clear diagnosis to optimize the right therapies and make sure we don't use the wrong therapies, and to be able to diagnose these babies as soon as they present. So we've just recently developed this diagnostic algorithm for Dravet syndrome based on these data that I have shared with you. And this really shows when you might expect the first seizures to occur, that to remind us that they may be afebrile, that these are the common seizure types, and the duration of the first seizure can vary from seconds to up to 3 hours. This is the time between the first 5 seizures, so that you know whether the baby that you've got in front of you could still fit with this diagnosis. These are the seizure types you'd look for in the baby to emerge over time, and the age of onset of subsequent seizure types if they were to get one. This is their developmental profile and when you might see developmental slowing become apparent. And finally, that whether they're at risk or to show they're still at risk throughout life of status epilepticus, and they're very likely to have fever sensitivity. So with that, I'll stop, and I'd like to thank very much the fantastic families with whom I work. This is at one of our last big family conferences in Melbourne a few years ago, including this little boy here with the early infantile profound SCN1A developmental epileptic encephalopathy. I'd like to thank particularly Wan Hui Li and Amy Schneider for the work delineating the criteria for Dravet syndrome, and more recently for their help with this work from Sophie Russ Hall, another one of my research team. And I'd like to thank all of the collaborators I work with for much of this work, Heather Meffords and her team, and many of my collaborators around the world. And thank you to the Dravet Syndrome Association for inviting me to be with you and to discuss this research. Thank you.